Hi everyone, this is my presentation on endometriosis. So here's our typical patient presentation. A 26-year-old female patient complains to her doctor that her periods are incredibly painful and heavy. She's had heavy menstrual cycles since she was 13, along with constipation, pelvic pain, and pain with intercourse. She says she is also struggling to conceive now and wonders if it's all connected. Here's a quote from a study about endometriosis. In a study of 1,000 women with endometriosis, approximately 80% presented with pain, 5% with infertility, and 20% with an endometrioma, or an ovarian mass. So that's just a quick glance at some common symptoms in endometriosis. One of the problems with studying endometriosis is that we don't really understand how it happens or why it happens, but we do understand that it is estrogen-dependent glands or stroma that happen outside the uterine cavity or the uterus. We have endothelial tissue, which should be the innermost lining of the uterus, growing outside of the uterus in the peritoneal cavity. And this diagram is possible sites where you might see some of those lesions. Up next, I have a quote from a study that was published in 2018 that was exploring potential treatment methods for endometriosis. Endometriosis has an increasing incidence affecting 2% of the general population, being the third gynecological cause of infertility, chronic pelvic pain, dyspareunia, and dysmenorrhea. We'll cover those later. Endometriosis affects 7 to 15% of women of childbearing ages, with 25 to 30% of sterility cases having a significant social impact. So again, we don't really understand the pathophysiology yet of endometriosis, but we do understand some of the risk factors seen and associated in women already diagnosed with endometriosis. The first being diethyl sylvestro exposure in utero, low birth weight, so potentially being born premature. We're still exploring, but we see a potential for a genetic predisposition. Exposure to endocrine disrupting chemicals, and an increased dietary intake of red meat and trans fats. A couple more risk factors would be the obstruction of menstrual flow, which would actually translate to what is known as Müllerian anomalies or uterine malformations. You can actually see a little bit more about this on page 803 of our textbook. But this is a congenital abnormality in how the uterus is developed, which can cause problems in the menstrual cycle. And then there's also a risk factor in prolonged exposure to endogenous estrogen, and that can be from early menarche, or starting your period early, short cycles, late menopause, delayed childbearing, or childbearing later in life, and obesity. So in terms of the pathophysiology, because it's still a little confusing to those who are studying it, we do have some associated characteristics. First, we do see that in high levels of estrogen, which are observed in endometriosis, there is also the enzyme aromatase, and that has been correlated and associated with severe endometriosis cases. There is evidence of cells switching roles, so to speak, during development, so stem cells moving or migrating, or other cells in what would be the body wall becoming endothelial cells. We do see that the role of inflammation and leukocytes might encourage further development of lesions, and some of the innate autoimmune responses can be correlated with tissue damage and might encourage some of that further tissue damage. Here's a little bit more pathophysiology. We do see that the blood vessel development early on can be associated with lesions. If these blood vessels are malformed, they can, kind of to colloquially say it, bring endothelial cells with them as they grow from the uterus out into the peritoneal cavity. They can take some of those endothelial cells with them, encouraging kind of a migration of endothelial cells outside of the uterus. We do see a bit of a connection of genetic and epigenetic roles, so environment versus some biological factors, and those are still being explored. And then, kind of similar to the blood vessel development idea and the other cell migratory theories that we'll explore later on, we do see some stem cells associated with lesion developments where there might be quote unquote mistakes and endometriotic cells migrate, causing lesions. So there are some developing theories regarding the pathophysiology of endometriosis. The most common and popular one would be the Sampson theory, also known as retrograde menstruation, and that is the idea that during menstruation, endometrial cells end up traveling up the uterine or fallopian tubes and end up in the general peritoneal cavity, where they just continue to grow into lesions. We have embryonic cell transformation, which is cell development that could be affected by estrogen or other hormones while still in utero, and they end up transforming into these endothelial cells, even though they're outside of the uterus. And then we have the choemic metaplasia or induction theory. And these are epithelial cells, or this is the idea that epithelial cells that already line the body wall or the peritoneal cavity end up developing into endothelial tissue. And this is a little bit more of a vague theory, but very similar to the embryonic cell transformation theory. One of the important things to note about endometriosis, like I've said, is we don't have a lot of information regarding how this happens. And even though we do understand endometriosis to be benign, non-carcinogenic, we do see about 1% of affected women experiencing some kind of malignant transformation where these lesions become metastatic and grow and become dangerous. So here are some signs and symptoms of endometriosis. First, we have infertility, potentially because of those uterine abnormalities. We have pelvic pain, dysgeusia, which is painful defecation, dyspareunia, which is pain with intercourse, abnormal or really heavy bleeding, specifically during a period, and constipation. And the reason for this is going to be similar to the dyspareunia, which is the painful intercourse, because if you remember the diagram on the second slide that showed potential places where lesions might form, some of those are on the rectum or put pressure on the rectum, and that can cause a lot of GI issues for the patient. Ideally, a diagnosis for endometriosis would be made through a laparoscopic surgery, but because that can be expensive and we know a little bit already, usually a presumptive diagnosis is made where a patient is prescribed pain medication and other medication, and if that works, that's good enough, and we can go off that as a diagnosis or a way of diagnosing. There is a classification system, stages 1 through 4, and it is a great way of identifying stages of lesion or how far they are in the adhering to the body wall or parts of the peritoneal cavity. But it is an imperfect system because even if you have maybe stage 1 where you only have a few lesions and they aren't very deep, the patient might experience a lot of pain, and so it's not necessarily a system that everyone can neatly fit into. Some treatment options include pain medication over the counter, hormone therapy for helping regulating menstrual cycle hormones, like hormonal contraceptives like birth control. Conservative surgery would be individually removing lesions. We have fertility treatment would be for those endometriosis patients who are struggling to conceive. And a less preferred method of surgery would be a hysterectomy and oophorectomy, but that can be kind of dramatic. And one study that I saw suggested and had success using desogestrel to successfully prevent endometrial cysts and their growth. In general, though, the most common treatment plan would be using nonsteroidal anti-inflammatory drugs, or NSAIDs, or birth control pills or other hormonal contraception methods, just for continuous management of endometriosis symptoms. But if those don't improve with these medications, other hormonal therapies might be tried. And then a last resort would be some form of laparoscopic surgery to better understand the condition and assess further treatment options. These are a couple potential surgical methods. Excision would be for lesions that are pretty small. Fenestration and ablation would be for completely removing parts of the cyst off the body wall and off other peritoneal tissues. And then ultrasound-guided sclerotherapy would be directly injecting alcohol or ethanol into ovarian cysts to kill them. Thanks so much for watching. These are my sources.